Dr. Joseph Connors. I'm based at the BC Cancer Agency in Vancouver, British Columbia, and the University of British Columbia, where I focus on the clinical care of patients with lymphoid cancers and related research. Brentuximab vedotin is a targeted agent, so it's a two-part molecule. One part is a monoclonal antibody that latches on to the CD30 determinant, which is on the surface of Hodgkin-Reed-Sternberg cells. That's the malignant cell of Hodgkin lymphoma. It brings with it, connected to it, a substance called monomethylauristatin E. Once it's inside the cell, the antibody is digested away. The monomethylauristatin E poisons the cell by disrupting the microtubules. So it's a neatly targeted agent that goes just after the malignant cells and spares the normal cells. The Echelon 1 is essentially the final developmental trial to examine the usefulness of brentuximab vedotin for Hodgkin lymphoma. Previously, we demonstrated that it's a very potent agent, works well for relapse disease. This is the frontline evaluation. So we combined it with 3 standard drugs, AVD, from the ABVD regimen, and compared that to the standard ABVD regimen, which has been available and used regularly for almost 30 years. So we did a simple, randomized, prospective, 2-arm trial comparing the experimental coupling of brentuximab vedotin with AVD versus ABVD for patients with stage 3 and stage 4 advanced stage classical Hodgkin lymphoma. The point was to find a treatment that works better than ABVD, defined as more efficacious, more effective, and still within the bounds of acceptable toxicity. And that goal was accomplished with the Echelon 1 trial. So we focused on whether the primary treatment seemed to be capable of eliminating the disease. So we looked as a failure of reaching that goal if the disease progressed after the treatment had been started, or if the patient died, or if the patient reached the end of their planned chemotherapy and had testing, typically with PET scanning, that demonstrated the disease was probably still persistent, and because of that, a doctor added treatment. So it required the coupling of the abnormal PET scan and the treatment to count it as an event. And we then summed up the number of events and compared the 2 arms, and there were simply fewer events on the experimental arm, demonstrating the increased efficacy. The A, V, and D includes a drug called vinblastine, and that has some neurotoxicity. When the brentuximab vedotin is finished working, some of the monomethylauristatin E leaks out and affects other cells, and that has some neurotoxicity. So they could add together, and people developed peripheral neuropathy. We found that happened in about 2/3 of all the patients, but the good news is that in those patients, with time, that neurotoxicity largely resolves. So we found that that improvement occurred. We also found that when we added the brentuximab vedotin to standard chemotherapy, there were more episodes of febrile neutropenia, infection in association with a low white blood cell count. By instituting a recommendation that patients be considered for prophylactic growth factor, GCSF, before their rounds of chemotherapy, or as part of their rounds of chemotherapy, the attempt was to block that from happening, and it was largely successful. So those 2 toxicities were kept within what I would call acceptable bounds. In addition, we had removed the bleomycin from the ABVD combination, and it is associated with significant pulmonary toxicity. On the ABVD control arm, we saw an excess of deaths during treatment from pulmonary-related toxicity, and eliminating the bleomycin provides us with safety there by avoiding the drug that causes it. For the past more than 30 years, we've been relying on ABVD to be the primary chemotherapy treatment for patients with advanced stage Hodgkin lymphoma. This opens up the option of changing to a different treatment which is more effective, as measured in our trial, but at the same time still within bounds of what patients can accept as the toxicity that's necessary for them to have successful treatment. So that's a new avenue of treatment. Clinicians will now need to make their own judgment about whether this is the appropriate thing to do for their patient. At least we know it works better and that it can be tolerated safely. Other considerations like cost will have to be taken into consideration, and ultimately decisions made country by country and clinician by clinician as to whether this is to be adopted. But at least we've provided them with the solid scientific evidence that it's more efficacious and can be tolerated within acceptable bounds of toxicity.